Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Understanding Quality Resource and Use Reports call. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Candy Hansen. Ms. Hansen, the floor is yours.
So we wanted to welcome everyone to today's webinar, which, as she just said, is Understanding Quality Resource and Use Reports, or the QRUR. From today's webinar, you will learn the difference between the 2015 mid-year QRUR and the 2015 annual QRUR. You will understand the components of the QRUR, and you will learn how you can receive no-cost assistance in optimizing your performance. We want to encourage you to ask questions in the chat box during this webinar, and we will do our best to answer them in the webinar. If we are unable to answer them in the webinar, we will have you get back in touch with us offline so that we make sure we get your questions answered. This webinar is being provided from the Lake Superior Quality Innovation Network, also known as the LS-QUIN. Last year, CMS regionalized the quality improvement organizations across the United States, and Medicare in Wisconsin, MPRO in Michigan, and Stratus Health in Minnesota are now collaborating as the LS-QUIN to improve healthcare for Medicare beneficiaries, share best practices, and maximize efficiencies. Quality improvement organizations across the U.S. are working on several initiatives between now and July of 2019. They are all listed here. We are working across initiatives wherever possible to align reporting programs and quality improvement efforts. Here's the contact information for PQRS and the Value-Based Modifier program for each of the 3 states. Before we talk specifically about the QRUR reports, I'm just going to review a few points about the Value-Based Modifier program, which began in 2015 for physicians in group practices of 100 or more eligible professionals. It came out of the Affordable Care Act and will score organizations by reviewing claims submitted to Medicare under a single tax identification number, or TIN. For the 2015 modifier, the adjustment will be based on calendar year or performance period for the year 2013. CMS has set aggressive goals and is implementing significant reform over the next several years to change the current fee-for-service payment system to a reporting, payment, and quality performance system. The Value-Based Modifier program is based on PQRS participation and cost and quality measures. The Value-Based Modifier program began in 2015, and by 2017 will have been phased in for all physicians and physicians groups. Again, the data for each of these phases is measured for the performance year that occurred 2 years prior. The payment calculation for the Value-Based Modifier adjustment will be based on cost and quality data, the results of which will be provided in the Quality Resource and Use Report, and will give you an adjustment that is either negative, neutral, but also can result in a positive adjustment, rewarding organizations who are providing high-quality, low-cost care compared to their peers. This slide, which if you loaded the slide deck prior to today, said 2015 VBM program. And so after some discussion, we made sure that we had the correct information. This is actually the 2016 Value-Based Modifier program. This is a visual of what 2016 Value-Based Modifier adjustment will be for the 2014 reporting period. So I apologize for that. As you can see, even for us, it's very hard to keep the reporting year and the adjustment year straight, and so we have frequent conversations about it. For the 2015 Value-Based Modifier program, it will only apply to EPs in groups 100 or more for the 2013 reporting year. Since this program is being phased in, this will be the first year for groups of 100 or more, and these folks will only receive a neutral or positive adjustment for 2015, that is, unless they elected quality tiering. If they did elect quality tiering for the 2013 reporting year, they also would be subject to a negative, neutral, or positive adjustment for 2015. Now we'll start talking about the Quality Resource and Use Report. We thought it would be helpful to understand the development and the history of the QRURs. In 2008-2009, CMS tested resource and cost measures with about 300 randomly selected physicians in 12 metro areas. In 2009 and 2010, CMS developed and tested feedback reports with about 1,600 physicians and 36 TINs. In 2010 and 2011, CMS distributed group-level QRURs based on the 2010 data to 35 TINs. In December of 2013, QRURs were produced for 54 TINs for 2011 data. In September of 2013, QRURs were produced for TINs that had 25 or more EPs in 2012 and also had 20 fee-for-service beneficiaries attributed to their TINs. In September of 2014, QRURs were produced for TINs that had one or more MDs who billed under the TIN for 2013. Throughout this process, CMS has collaborated with stakeholders, reached out to physician and medical specialty groups, sought input from QRUR recipients and medical associations, as well as held public listening sessions to get feedback for future changes to the report. In April of 2015, mid-year QRURs were made available for the first time to physicians who billed Medicare-covered services under a single TIN over the mid-year performance period. You'll note that that performance period was different than what the annual QRUR performance period is. This fall, either late in September or early in October, we've been told, the annual QRUR for 2015 will be released to physicians and non-physician eligible professionals, including Medicare Shared Savings Program, Pioneer ACO models, or other initiatives to include value modifier information for those TINs that are subject to the 2016 value modifier. And again, that would be based on the performance period for care provided in 2014. So who can expect to receive an annual QRUR in 2016? All solo practitioners and groups nationwide will be receiving them by 2016. Again, they're identified by TINs. They had one eligible case for at least one quality or cost measure, regardless of whether the 2016 value-based modifier would apply to them. And they will be used to will be able to use the QRUR to see how your organization compares with other TINs caring for other Medicare beneficiaries. So some organizations did receive a mid-year QRUR in April of this year. The mid-year QRURs are designed to be informational only, for informational purposes only. The information is about performance only on cost and quality measures that the Centers for Medicaid and Medicare Services calculates from Medicare claims. You'll note the performance period was 7/1/13 to 6/30/14. PQRS data will not be included in mid-year QRURs. They will not impact Medicare fee-for-service scheduled payments, and they are not intended to predict future value-based performance. The 2015 annual QRUR, which will be released shortly, will serve as the final summary report on quality and cost performance. For this year, we'll report your value-based modifier adjustment for TINs with 100-plus eligible professionals. The modifier will be used to adjust your Medicare payments to physicians for the performance period of calendar year 2014. This report takes information on all quality and cost measures to compute what are known as the quality and cost composite scores, which I'll talk more about in just a minute, and includes PQRS data that has been reported. The annual QRUR will allow each TIN, again, to compare its performance on each measure to that of its peers. I'm going to answer in just a couple of minutes what happens if you didn't report PQRS data in 2014. Accompanying the annual QRURs will be the supplemental QRUR. These are confidential feedback reports for solo practitioners and practice groups, and these provide much more detailed information on the Medicare beneficiaries who impacted your QRUR. The 2015 supplemental QRUR is based on episodes of care and is supposed to also be for informational purposes only. The data in this report complements the per capita cost and the quality information provided on the annual QRUR. Finally, the information listed in the supplemental QRUR is also not incorporated into the 2016 value-based modifier. The information that you will be able to see on the supplemental QRUR is gender, date of birth, risk status, fee-for-service claims filed, services provided, the chronic conditions that you are caring for, and information on hospital admissions. So, what information is found in the 2015 mid-year QRUR? Performance data on CMS calculated claims-based measures only. It includes the 3 quality outcomes measures, 2 composite measures of hospital admissions for ambulatory care-sensitive conditions, and 1 measure of the 30-day all-cause hospital readmissions. This is what the mid-year QRUR looks like. Keep in mind that the performance period for the mid-year QRUR is different than that for the annual, as is the report itself. So first it tells you eligible professionals billing to your TIN. And this part of the mid-year QRUR shows the attribution of your Medicare beneficiaries and episodes to your TIN. And I'll talk more about attribution in just a minute. And then here's how it calculates out the outcomes measures that CMS has chosen for the mid-year QRUR. This is just for your reference. And then finally, this part of the mid-year QRUR shows the hospitals that account for at least 5% of inpatient hospitalizations during the performance period for beneficiaries attributed to your TIN. So, what's in the 2015 annual QRUR? Performance data basically it's your performance data during calendar year 2014. It includes all cost and quality measures used in calculating the 2016 value-based modifier. It contains the quality and cost composite score that determines the TIN's 2016 value-based modifier adjustment. For TINs with 10 or more eligible professionals, it will tier cost and quality information, ranking the TIN either high, low, or average. And it will include benchmarks to compare your performance to that of your peers, as mentioned before, when it is accompanied with the detailed supplementary information. I updated this slide because I had the annual QRUR from the year 2013 in the previous slide deck. So this one's updated to have the 2014. So this is what your 2015 annual QRUR will look like. You will see your TIN's quality composite score, your cost composite score, and your quality tiering performance as compared with other TINs. And again, I'll break down the quality and cost scores shortly. The 2015 annual QRUR is risk-adjusted for high-risk patient care if you meet all 4 eligibility criteria and categories listed here. And then finally, you can see that it reports to you what you can expect for your value-based payment adjustment for 2016. Another note is, so what number is, if you're high quality and low cost, what is that AF number? So this is a budget neutral payment adjustment. So that will be determined by the positive payment adjustment will be determined by the amount of dollars that are in the budget based on the people who weren't performing as well as those who were with high quality and low cost. So how are beneficiaries attributed to TINs in the QRUR? They are attributed for 5 per capita cost measures and 3 claims-based quality outcomes measures calculated from Medicare administrative claims data. Beneficiaries are attributed using a 2-step approach with a process that's similar to the approach used to assign beneficiaries to accountable care organizations under the Medicare Shared Savings Program. If you look up the FAQs for QRURs, which we will provide a link to at the end of the presentation, and you go to page 9 of that document, under question number 7, you will see what the 5 per capita cost measures and the 3 claims-based quality outcomes measures are. So, is the same population of Medicare beneficiaries included in all of the cost and quality measures? The answer is no. The populations are intended to broadly represent the fee-for-service Medicare beneficiaries in each group, so the methods for defining the populations differ. Okay, so here are the quality categories that make up the QRUR. Hospital admissions for ambulatory care-sensitive conditions measures, so acute conditions composite and chronic conditions composite, the 30-day all-cause hospital readmissions, Medicare spending per beneficiary, and quality measures reported through PQRS. Now, we have asked the question to CMS, and I'm still waiting to get absolute clarification on this answer. But since the QRUR reports both cost and quality and PQRS measures, if you didn't report PQRS measures in 2014, would you still receive a QRUR to show you where your cost and quality measures are rated? And as I said, I'm still waiting for an absolute definite answer to that question. However, even if the answer is no, and you didn't get a QRUR this year, it's still important to know what the components are for cost and quality so that you can drive your quality improvement efforts in that direction. So just a note about the quality measures that were reported for PQRS. The measure population will vary depending on the method in which you reported. So if you reported as an individual via claims, qualified registries, or directly out of your EHR, the measure population may be different than if you reported via a group reporting through the GPRO web interface, or as an individual via qualified registries, or if you reported through the CAHPS assessment data. So here are the cost categories for the 2015 annual QRUR. Per capita cost for all attributed beneficiaries, per capita cost for beneficiaries with specific conditions, and those conditions are diabetes, coronary artery disease, chronic obstructive pulmonary disease, and heart failure. And then per episode cost for the Medicare spending per beneficiary. So a significant consideration for this, for which costs apply to the value modifier, is that you'll note all cost measures, including those associated with inpatient, outpatient, skilled nursing facility, home health, hospice, durable medical equipment, and non-institutional provider/supply services will be included in those cost measures. You'll note that Part D, outpatient prescription costs, are the only exclusions. So why are hospital-based costs included in cost measures for TINs? CMS seeks to align incentives and encourage care coordination across settings. It's based on the assumption that the TIN providing the plurality of services to beneficiaries over the course of the performance period or during a hospital episode are well positioned for influence. In other words, they're pushing that envelope even farther for us to collaborate together to care for the patient as a team across settings. So did CMS account for differences in Medicare payment rates for cost measures? CMS standardized the unit costs. They removed geographic Medicare payment differences, risk adjusted to account for medical history differences, and specialty adjusted to account for differences in specialty mixes. This, in the FAQs, you'll find this table in here just to give you a comparison of the 2014 mid-year QRUR and what is in it and what's not in it, and then as well as the 2014 annual QRUR, showing the difference in performance periods, and then the exhibits that accompany each of those reports. So I just wanted to say one word. We received notification that the Centers for Medicare and Medicare Services recently announced that various errors were discovered in the 2014 Physician Quality Reporting System data submitted by vendors on behalf of physicians and group practices that reported via electronic health records and qualified clinical data registered. Physicians who participated and reported in 2014 PQRS through claims and clinical registries are not effective. So as you can tell, that's going to cause some issues with calculating quality performance. And so at this point, we believe that we're being told by CMS that there's no need for physicians or group practices to submit a PQRS informal review request. And it says for PQRS and the Meaningful Use EHR incentive programs, there is no impact because physicians are judged on whether they successfully reported rather than on their actual performance. Simply receiving the data will allow CMS to deem those folks as successful for purposes of avoiding the payment adjustment in 2016 for 2014. The score for those that the data had some issues with will be based solely on the claims-based outcomes measure and the CAP survey, if applicable. So just wanted to give you some information about that because we're aware of that. So now I'm going to turn it over to Laura, who is going to talk from MPRO, who's going to give you information about how to access your 2015 QRUR reports. And Laura, just before I do, I did just receive an email from someone who's participating with us in this PQRS and value-based modifier, and she reported that they were having trouble with the portal, with accessing this portal. So I don't know if others have been having trouble. If you have been having trouble, we just put that in chat so we can just be aware of the fact that there's a bigger problem out there. And so now, Laura, I will turn it over to you.
Thank you, Candy. So as mentioned, we are going to go through how to access your QRUR report in the CMS's portal. The portal is listed here. It's portal.cms.gov. And once you go to that portal, you log in using your EIDM credentials. For those that are not familiar, if you have an IX account, previously you accessed the portal using your IX account, but the IX did transfer over to the EIDM on July 16th of this year. So if you haven't done so yet, you do want to log in and verify your account. If you didn't have an IX account previously, you would register with the EIDM to be able to access the portal. So once you're logged in, you'll see the PQRS drop-down from the top of the screen. Once you click that, a drop-down menu will appear and you will select QRUR report. This will take you to this screen. You'll see the select a year drop-down and you'll select the year that you want your QRUR report. Some of you, depending on your group size and when you were phased in, you might have multiple reports or you may just have one. You also should have the mid-year QRUR report that was available in April. So once you have the QRU report selected, it will take you to this next screen here. Here, this will list all of the practices that are associated with your EIDM account. Again, depending on your group, you might have multiple practices listed or you may just have one practice listed. If you have multiple practices listed, you can search in the search bar by name or by entering the last 4 digits of the TIN number to pull up which practice you want to pull the report for. Once you choose your practice that you want to pull the report for, you simply highlight them and then move them over to the selected box, and you can do that either by double-clicking or by using the over arrow. Once the practice is moved from the available section to the selected section, you click Run Document, and then you do have to give it a few minutes just to generate the report. Also, just as a side note, if you have multiple practices listed in the available box, you can only run one report at a time, so you can only choose one report and move that over to selected. Okay, moving on to the next slide. Once you've actually ran your QRUR report, the report will be shown in the portal. It'll look something like this, and along the top of the screen you'll have the different tabs that help you navigate to the different sections in the QRUR and what information those provide. You are available to PDF that report by simply clicking the PDF icon at the top of the toolbar shown here. Once the report is PDF'd, you will see on the left-hand side now those bookmarks that help you navigate the report, and then you can also print the report by clicking the print button on the toolbar. So that is how you pull a QRUR report, and that is part of the assistance that the LSQIN does provide. And then that concludes today's presentation on QRUR reports. We do realize that this is an incredible amount of information, and we know how difficult it is to keep it all straight. We would like to remind you that the LSQIN is here to help you through this journey. Our education and technical assistance is free of charge, but it does require a commitment from you to successfully report PQRS measures and to set quality improvement goals, which we will work with you on achieving. The LSQIN's assistance relates to all of the initiatives we talked about previously and includes PQRS, value-based modifier, and meaningful use assistance. We encourage you to get in touch with your state QIN/QIO contact person to learn more. If you are not yet aware, PQRS, meaningful use, and value-based modifier will be morphed into a program called the Merit-Based Incentive Program, or known as MIP. The earlier you are engaged in this work, the better positioned you will be for the transition in 2019. We do have limited resources to assist in this work, and we have already engaged many providers at this time. We are afraid at some point we may have to turn people away from the technical assistance aspect, so please get involved sooner than later. The benefits of participating with us, we believe, are many. We are working to create an all-teach, all-learn environment and will continue to provide ongoing education to keep you up to speed and informed of the ongoing changes that you will be working through. All of our education sessions are recorded, and you can go to the LS2N website to view or view again any of the sessions we've already offered. Here are many different references provided that regard the QRURs, so please visit these for your own benefit. Again, here is the contact information by state for the release for the PQRS value-based modifier work. Thank you again for joining us today, and these slides will be available on our Lake Superior QIN YouTube page within the next week. At this time, let's pull up the evaluation questions. Please take a moment to let us know how we did by filling these out. And we'll also take a minute now for any questions you may have.
Certainly, the floor is now open for questions. If you do have a question, please press the number 7 or the letter Q on your telephone keypad, and questions will be taken in the order they were received. If at any point your question has been answered, you may press 7 or Q again to disable your request. Please hold while we wait for the first question. Again, if you do have a question, please press the number 7 or the letter Q on your telephone keypad. Ms. Sawyer, it appears we have no questions at this time.
So this is Candy again. So if you do have any questions, please feel free to get in touch with any of us, and we will be happy to either answer them or work to get an answer to them if we don't happen to know the definitive answer at the time of the question.
We do have a question that just came in from Daniel Spurn. Daniel, please state your question.
Yes. My question, if a provider chooses not to participate in PQRS, they are, as my understanding, they are subjected to a penalty. Is that true? If so, what is it? How is that determined? If a provider says, I'm not going to do PQRS, I won't report it, I don't have an interest.
So this is Candy, and I'll start by answering the question, and Laura and Marnie, the one thing I can't remember is what the penalty percentage is this year, so if you happen to have that information. So we have gotten this question from several providers, and yes, there is a penalty this year if you choose not to report PQRS data. So, but it's a little more complicated than that. So if you did not report meaningful use, if you're not attesting to meaningful use, there's a penalty associated with that. On top of that, if you choose not to report PQRS data, there's a penalty associated with that. And then ultimately there will be a penalty associated with your quality and cost because of not reporting PQRS data out of the value-based modifier program. So it's a cumulative effect, which I believe it can go, the cumulative effect is up to 9% of your Medicare revenue. And so that's one answer. The other answer is that I tell people is that because there are provider organizations that say, you know, I'm just going to do a return on investment calculation and determine whether or not I should do that. While I understand that perfectly well, I think that there's that things are changing so quickly that there's a very fine balance between when you've chosen not to report and improve your quality measures, and the point at which there will be others that have improved so much more than your organization that I believe that it has the potential for impacting future business at some point. Does that answer your question?
Yes, thank you.
Marnie, Laura, do you have anything to add to that?
No, I think that you covered it great, Candy.
Are there any other questions?
At this time, it appears we have no further questions.
Okay, and as Laura mentioned, we really would like to get your feedback in this very brief survey, so if you could take a minute and answer that. And again, get in touch with your state's contact person if you have additional questions or would like other information or would like to participate with any of the states in the PQRS value-based modifier initiative. We thank you very much for your time today, and we give you the gift of time because we're 20 minutes early. So have a great day, everybody.
Thank you. This does conclude today's teleconference. We thank you for your participation, and you may disconnect your line at this time.